and get started. All right, today we are having our first pediatric Gumbeaux webinar in our new series. We are just delighted to have Dr. Warrier presenting prevention and early recognition of stroke in children with sickle cell anemia. Dr. Warrier has been taking care of children with cancer and blood disorders in Louisiana for 40 years at LSU, Children's, and Ochsner. He has worked in clinics in NOLA, Baton Rouge, Lafayette, Bogalusa, and Monroe. Dr. Warrier has published and presented more than 400 papers and abstracts. He has been honored by the Louisiana AAP, winning both the Chapter Service Award and Master Pediatrician. Dr. Warrier loves to teach and has won Best Teacher Award from LSU, Tulane, Ochsner, University of Queensland, and Children's Hospital of New Orleans. In order to be more accessible in this webinar, we have enabled closed captioning. So please look to the bottom Zoom toolbar to turn on closed captioning on your end. You may need to click the 3 dots that say more to turn on the closed captioning option. Okay, brief disclosure statement. For this webinar, no one has any relevant financial relationships to disclose. And I will pass the baton over to Dr. Warrier to start the presentation.
Can you let me share screen?
Yes, please.
Okay. Let's see. Thank you, Julia. And again, I said, I'm so proud to see you. I know your dad very well for many, many years. Good to see you still helping pediatricians all over the state. For those of you who are listening in, what I'm going to try to do today, and thank you for the introduction also, Julia. What I'm going to try to do today is to since the audience is very varied, we've got hematologists listening. So I'm going to just try to first very briefly cover history of sickle cell and some of the complications, about maybe 5-10 minutes, and then go over the strokes. I'm going to show a lot of pictures, so don't try to take notes, just sit back, listen, and don't even read the notes, but just listen to me, okay? This is just a fun way to get to know about strokes and sickle cell. So I show this picture because as Julia said, I've been working all over the state for many years. Those who remember this old charity hospital, I'm very proud to have worked there for many, many years because we took superb care of sickle cell patients there for many years. We're a combined clinic, LSU, Tulane, children's, adults, with everything for many years. But unfortunately, Hurricane Katrina closed it down. And this is LSU Children's. Now, again, I'm showing this picture because I don't know if anybody's listening in from Louisiana Sickle Cell Foundation, but we have very good across the state foundations, clinics, and the Louisiana State Commission does a lot of very good work compared to many states. So it's a meeting that we hold every year in Louisiana to teach patients, parents, and doctors about sickle cell. And I'm very proud to say that my students and residents are very active. There's one group that presented papers this meeting. So again, it's a chance to learn about sickle cell, also become academic. So I'm very proud of the commission and my students. Okay, so, and I'm at Oxford now. They have a good sickle cell clinic there also. Again, we already talked about the objectives. I won't repeat it again, but I want to remind you there's a picture from my clinic in the old charity hospital. We had adult, pediatric, LSU, Tulane, everybody together. And I'm very proud of this picture. This is a patient of mine holding the baby. And many years there's a mom. It's the same patient with the baby. So that's a success of sickle cell anemia over the last, we've been able to look after them very well. If you had sickle cell anemia in the 1950s or 60s, your chance of being about 18 only about 45%. Now it is close to 95%. So again, because of screening, antibiotic prophylaxis is changed dramatically. But we do have complications, but at least successfully they're able to go through pediatric, become adults in most cases. Again, I don't have a disclosure, but I did as a fellow president do a lot of and staff do a lot of work in sickle cell, but at this point in time, I have no disclosures. Okay, I want to thank my colleagues at Lake Charles, Lafayette, Baton Rouge, Alexandria, Monroe, Bogalusa, and Shreveport, where for Louisiana, there's a lot of clinics across the state. So we took good care of sickle cell patients, especially as children. I don't know, adults are more difficult, but children always got very good care. And thanks to the Sickle Cell Commission and the Louisiana Department of Health, because we have worked very closely together for many, many years. And again, I'm very proud to show my students and residents who became a doctor, sickle cell anemia, to excellent care of patients, Lafayette for many, many years. So these are my colleagues at Auctioner. Again, we had good nurses, so we've got a good team. Doctors, I'm a nurse at Children's Hospital, and as an Auctioner, students and residents, all of us together take good care of sickle cell patients, social workers, everybody is a team. Okay, Julia is the first poll for the audience. If they can do this for me. What is diagnostic electro? So newborn screening is available in Louisiana. Again, thanks to LSU, Tulane, and the state program for the last almost 35 years now. So anybody wants to answer this question?
We have people answering the poll in their Zoom screen. We have one answer so far. So out of 5 or 6. So we're gonna give a couple minutes or a couple seconds for you to answer, please.
15 seconds, yeah. Okay. Nobody responded so far, but anyway, the correct answer is.
All right, we have one response for FAS.
Oh, correct. That's absolutely correct. So 100% accuracy. Very good. 100% correct. So FAS is the screen. The reason I'm showing this as a pediatrician, as a nurse, this report often comes back to you. Very FA is a sickle cell trait. FA is sickle cell anemia. FA is normal. Very good. 100% correct. Good audience. Very good. So this is FC, and this could be alpha thalassemia. So this is sickle cell trait. Nothing needs to be done. Just followed. Very good. Okay, next question. Again, another question here. I'm supposing would you choose to have SS, SC, S beta plus thalassemia, or H sickle high F, or SO Arab? The choice, which is the most severe, which is the least severe. 15 seconds. Okay, I think only. So answer would be. Anybody?
I don't think that.
That's okay.
You're quite sure on this answer. We've got none coming in.
Okay, answer is D, because hemoglobin F protects you from getting sickle cell symptoms. The high F holds on to oxygen. You can decrease sickling, so it's hemoglobin F. So this is high F. That's why we give hydroxyurea to give the hemoglobin F. The last question I'll answer myself is this is about our topic today. Prevention of CVA is best done by using transcranial Doppler and transmission indicator. This is answer is C again. So aspirin does not prevent hydroxyurea. We don't know for sure. Indara and intermittent transmission not useful. Answer is transcranial Doppler with transmission indicator. Thank you, Julia. Okay. So very quickly, for those who are listening in, if you want to just read one reference, is the best reference. It's a little older, but it's the best reference available from NHLB. I think everybody who's take a sickle cell should have this with you. Evidence-based management of sickle cell disease. It covers all aspects of sickle cell anemia and what to do. It's again published in JAMA. It's available for those of you who want to read. Okay, I'm not looking at the chat. If you have any questions, feel free to stop me anytime you want. If you have any comments, suggestions, I don't mind being interrupted at all. I'm going to quickly through some of the complication history. Just don't read, just listen to me. So sickle cell was first maybe 8,000 years ago in Sahara. One little girl or boy got sickle cell. Nothing happened for some time because there was not enough malaria at that time. As they moved across the world, it became a protective effect. So more and more sickle cell trait patients got sickle cell disease, moved across the world from Africa to Middle East, to India, to Asia, to then probably over to the United States, all over. So they spread over. So many different traits and types of sickle cell anemias, and even within sickle cell SS disease, there are many different phenotypes, Benin, Arabian, Indian. So a lot of clinical variations, sickle cell anemia, different subtypes and different variations. Again, I want to stress the fact that the first disease ever in the world to have its molecular basis confirmed. It is the first disease we're able to say this molecule is abnormal, this chemical activity happens, and you get sickle. The first disease in the world to have molecular basis confirmed. Been diagnosed from 1910 when I was in a student in Chicago. I want to show one this picture, Janet Watson. Again, just to show you that women in medicine are still not recognized very often. This lady recognized hemoglobin F effect in 1948. We started using hemoglobin F, hydroxyurea in maybe 1990s, but still no credit is going to her. Okay, so I just remember this lady in 1948, they would describe hemoglobin F had protective effect. So it's found across the world, all over the world, now in many parts of the world, in India also, we see quite a lot of sickle cell anemia in many parts of the world. Here the normal RBC by scanning EM, the sickle cell that deformed because of the disease. Again, there's a molecular defect. I'm not going to go in detail about this because most of you know, but basically the one amino acid being substituted for a different one that causes abnormal sickle cells to become sickles, block the vessels, and cause all the pathology. Talk about hemoglobin F. After 6 months of age, hemoglobin F is relatively high. There are very few symptoms of pain, crisis, etc., but they still have got risk of infection. So it's very important to make sure that you have antibiotics early in life. So sickle cell anemia, pain, crisis, etc., stroke, etc., rare till about 6 months of age. Stroke rare till 1 year of age because of the hemoglobin F. There are different variants of sickle cell anemia. There are different syndromes. SS disease is the most severe usually. SC disease is less severe. S beta 0 is as bad as SS disease in most cases. S beta plus thalassemia has got. So there's modified by abnormal different hemoglobins. So very important for you to have correct diagnosis of each patient because the management depends upon the SS, S beta 0, S beta plus, etc. Again, there's different varieties of sickle cell anemia. This is a patient with CC disease, known as non-sickling disease. Here is sickle cell anemia. Okay, they get chest syndrome. Is the most common cause of death in children with sickle cell anemia today. Hypoxia, pulmonary infection, pulmonary infiltrate, sickle cell anemia, and fever is called chest syndrome. In early diagnosis, knowing patients with sickle cell anemia, you can manage them and help them. In pneumonia and other infections, become much less common because of the vaccinations. When I was a resident and before as a medical student, we used to have almost 100 times, 200 times more common infections, sickle cell, with pneumococcus and meningococcus, but now we rarely see them because of vaccination. So again, pneumonia. We'll talk about stroke in detail, but again, when I was a medical student, resident, we saw a lot of patients with stroke with significant complications and mortality. It's a patient of mine who had stroke, multiple stroke, actually died, and it's autopsy showing multiple infarcts in the brain. So stroke was a very major cause of morbidity and mortality. It's again, as I said earlier, if you've got SS disease, all complications more severe. S beta plus comes next, but SC and S beta plus thalassemia are much less common. So more severe, less severe. In lifespan, if you got SS disease, you got a shorter lifespan. SC has got longer lifespan. This is SS disease, SC disease, and normal. So definitely decreased lifespan for SS disease, little bit of SC, but both are less than the normal. And it's improving with better care from 1960s, 70s, much better care for sickle cell, but still we are far below expected. Pediatrics, again, as I said earlier, we've been dramatically changed outcome in pediatrics. I've been a doctor for almost 50 years now, last 40 years in Louisiana. And thanks to the newborn screening, excellent pediatrician, good sickle cell foundation, commission, education. I've not seen a patient with sickle cell die in the last several years because of excellent care overall for children. So you can see here, pediatric sickle cell patients have the same lifespan as the other children. And sickle cell trait, I'm not going to again detail, but generally they're healthy, except for a few complications, exposed to hypoxia, over dehydration, or sometimes there's a higher incidence of tumor called renal cell carcinoma. So please remember, sickle cell trait children, often they're underdiagnosed or unknown. If an African child comes with hematuria, make sure they're not sickle cell trait because they can have this cancer called renal cell carcinoma. So it's found much higher incidence in sickle cell trait than sickle cell disease, any other condition. In pathophysiology, because of abnormal red cells, abnormal oxygenation, damaged endothelium, nitric oxide, a lot of pathology. It causes change of blood vessels, leads to all the complications we talked about. And again, complications much more common in adults, fortunately in children, because of time, better care, better supportive care in general. Complications are less, but as they grow older, all these things accumulate. Kidney, heart, lungs, etc. accumulate as they grow older. Diagnosis made by, again, I'm very, very proud to be in Louisiana. We do 3 tests at birth for diagnosis. And I'm very proud that we have not missed a child for the last several years. So everybody's diagnosed at birth, that's for the pediatrician, the hematologist. The rule is they start antibiotic within 2 to 3 weeks. So we can do electrophoresis, can do isoelectric focusing, HPLC, and the diagnosis almost always conclusive, and almost, I don't know any cases misdiagnosed in our system for the last many years. So last question again, this is, I answer, you're the only doctor in town, and patient comes with a newborn baby is brought to you with sickle cell disease. What the first thing you will do? So you will start penicillin. Okay, as I said earlier, because of the high hemoglobin F, they may be asymptomatic. They may not have any pain crisis, but their immune system is still defective. They can die of septicemia. Again, just an old story. Before we had screening programs, before we knew about sickle cell disease, in infants, they would come to us dead, then we would diagnose sickle cell anemia. So because of penicillin prophylaxis starting early, that's almost completely eradicated. So as soon as they diagnose sickle cell anemia, give them penicillin prophylaxis. Okay. Again, so the newborn screening, start penicillin prophylaxis. So hemoglobin F has a protective effect. That's why we give hydroxyurea. I just want to mention here, we don't have clear evidence of hydroxyurea protect against stroke, but there are some new studies that show it may be effective. Come down in a few minutes, but hemoglobin F, very important role in sickle cell anemia progression. There are some studies where they're doing gene therapy to increase hemoglobin F, etc. But just remember, hemoglobin F is a very important factor in sickle cell anemia. So there are different genotypes. In general, if you've got SS disease, very low hemoglobin F, very low hemoglobin level itself, and high WBC, complications usually more. This is a pain crisis, a vaso-occlusive crisis. I just want to mention one thing: the adult hematologists, and especially people in the ER, do not use meperidine or pethidine because it increases risk of stroke in children and adults. So in general, in sickle cell anemia, we advise, unless no other choice, not to use meperidine or pethidine or demerol for pain crisis. So you can get in splenic sequestration. Again, this splenic sequestration, you can see damage to liver and spleen. You get hepatobiliary complications. Liver can have a lot of, including gallstones, and sequestrate the liver. The reason I'm showing all this is that people with infection, people with other complications have higher risk of stroke also. Okay, you get a parvoviral infection, acute anemia. So parvoviral infection, respiratory chest syndrome, any other crisis increase the risk of getting a stroke following that. In priapism, another complication happen. Any infection increase the risk of stroke after infection. So penicillin prophylaxis has dramatically changed the outcome of sickle cell patients. This study was first done in West Indies. Everybody gets prophylaxis at 5 years of age. I just want to mention this picture again just to remind you, in Louisiana, we have a very good mixture. This is from Ochsner, doctor from Tulane, the doctor from Public Health, doctor from LH, everybody all together. This is a very good study that we did about 2-3 years ago. And just want to stress the fact that people with children with sickle cell anemia in New Orleans, because of the good pediatrics, good hematology, good nursing care, etc., they get better immunizations than the general population. The study that showed that within New Orleans, the immunization status of children with sickle cell anemia is better than those with not with sickle cell anemia. So screening, they should have good pediatrician, good primary care doctor to make sure that kidney is screened, pulmonary hypertension, pulmonary disease screened for, cardiac complications screened for, retinopathy is very important, sickle cell anemia, from about 5 years of age, screening for bone disease, necrosis, femoral head. So they're all in a good medical home, primary pediatrician, hematology care, and of course, family education and community support. So this is coming to our specific area of stroke. I'll present a case today and then go on from there. Are you guys with me still? Everybody, can you follow me, or anybody has any problem?
So far, so good.
Okay. So here's a case here. It's a little baby patient of mine who's being followed by us some years ago, unable to walk one morning when he woke up. And the mother is very knowledgeable because we educate by foundation, by the sickle cell education system for patients good in Louisiana. Patient comes as part of the ER immediately. ER is knowledgeable because they see a lot of children with sickle cell anemia. So exam showed hemiparesis. An immediate CT scan is done, showed a stroke. In the ER itself, they were able to get the blood grouping and tapping done. Child got exchange transfusion. And I'll tell you the story a little later on. So this is a patient with a classic picture of stroke. Before the days of the screening and diagnosis is very, very common. So everybody in the ER knew any sickle cell anemia, but not any clinical symptoms suspect stroke. So this is a very complicated picture. I just want to show you multiple areas in the brain where sickle cell anemia can affect and cause problems. Multiple areas. I can't go through all of them, but you can see moya disease. You can see occlusion of blood vessels, okay, so hemorrhage, multiple complications. We'll talk about a few of them right now. But moya, vascular occlusion, stroke, what do we call infarcts that are quiet cerebral infarcts. These are all things that we'll talk about in a few minutes, okay? So it's a very major complication. They said I've gone through the spectrum of people dying in front of my eyes from stroke, having hemiplegia, having aphasia, and then coming back with more strokes. So really a terrific, terrible complication of past. You all know what the symptoms of stroke, but please remember sickle cell anemia, especially in children, can be very, very varied. It's acute injury of the brain, retina, or spinal cord, not caused by trauma, but due to ischemia or hemorrhage. So not because of a head injury, but because of ischemia or hemorrhage. Clinical, again, classic symptoms of stroke, but in children, can be sometimes seizures, altered sensorium, altered consciousness, or gait disturbance. Like our patient could not walk, she was crawling. So gait disturbances. So suspect stroke, persistent headache, visual symptom, diplopia, sleeping too much. In a child with sickle cell anemia, call the doctor. Again, it often can occur by itself without any warning or other complications, but very often follows infection, pain crisis, aplastic crisis, and chest syndrome. I've been doing this for many, many years in thousands of sickle cell anemia patients. My main concern, parvoviral infection for some reason, and then especially chest syndrome. I've not seen a stroke for quite a few years now because of good monitoring, but we had one patient who had normal TCD, but acute chest syndrome, and following that got a stroke. So chest syndrome, because it caused hypoxia, as well as infection, inflammation, and definitely predisposed to stroke. Very important. So chest syndrome, aplastic crisis, if you see, monitor for stroke carefully. And once you have a stroke, almost 75% are left with permanent disabilities, motor disability, hemiplegia, monoplegia, etc.
Dr. Warrior, I have a question.
Yeah, please.
So not related to stroke, but for acute chest in general. I know the guidelines for transfusions and red cell exchange in acute chest, is a little bit leaning towards try simple transfusion if the acute chest is mild, and then for more moderate to severe acute chest, try red cell transfusion. But the whole concept of red cell is to really decrease the sickle S percentage, as close to or below 30% as possible. How much would a simple transfusion really help decrease the percent S? And are we really getting any benefit from a simple transfusion?
Yes, that's a very, very good question. In fact, we have fought over this for many, many years. And as I said, I agree totally with you. The general recommendation is very, and this is very, very vague, not specific recommendation. It's got very early on, child is looking clinically well, try a simple transfusion. But in general, as you very correctly said, the hemoglobin is 9 grams, and you give a simple transfusion, you may increase the viscosity, increase the risk of thrombus. So I agree with it totally. If the child looks sick to you or suspect chest syndrome, probably an exchange transfusion as quickly as possible may be the most beneficial. But recommendation still is to use a clinical judgment. The child is very early on in the course. Hemoglobin is, and you can small transfusion, give transfusion, oxygen, fluid, and see what happens. But I agree with you totally. The concept should be to increase hemoglobin without sickle cell as quickly as possible. So an early exchange. I would leave that to our clinical judgment as a good doctor to do that. That's my opinion. But recommendation still is early transfusion, simple transfusion.
Okay, thank you. So if the hemoglobin is, let's say, more around 6 or 7, I think it's safer to give a simple transfusion.
Exactly.
But if they're higher, then even if they're not severe acute chest, or if you feel like their oxygen needs are getting worse, then I would rather quickly do an exchange than wait for them to get worse before I do an exchange.
Yeah, actually, I want to tell you the last case I went through with my colleague is exactly what happened. You said they took time to exchange transfusion. They wanted the central line, the child took the OR and got a stroke. So I would agree totally with you. Good job. A high hemoglobin, exchange transfusion as quickly. Lower hemoglobin, try a simple transfusion, but have things ready for an exchange transfusion.
Thank you so much.
Thanks, Ashwin. So just definition of stroke. So we'll go through this thing in the next few minutes. Stroke is what we all know. The stroke, TIA, again, all of us know, is a transient ischemic attack where people transiently lose their consciousness, get symptoms, come back to normal. Silent infarct, something very new and very important, sickle cell anemia over the last few years. We'll go over that also. Then there's a new thing. This is very new. I don't even have enough knowledge about, but it's tissue-based new MRI and MRI technique that shows infarcts much earlier than what you suspect before. We'll talk about briefly in the next later on. That's called transient clinically acute silent cerebral infarct. So there are not even be clinical symptoms, but may show some MRI changes. Okay, so So this is the classic infarct that we see, types of stroke in pediatrics. It's almost always ischemic or thrombotic, very rarely infarctive, less than a few percent infarctive or bleeding, because babies have got stronger blood vessels, they don't rupture easily. As you grow older, hemorrhagic stroke becomes much more likely. In adults more than 20, like 25, 25, most strokes are infarcted. Okay, so because of aneurysms, vessel damage, etc., most likely hemorrhagic. So silent infarct, as I told you, this is very, very important in pediatric now. Dr. Debon, who's done a lot of research in this. We have some WashU earlier. There's a lot of research. If you do CT scan, MRI, healthy children, find many of them have got silent infarcts. We'll talk about that in a few minutes. That area, they may not have any clinical symptomatology, no stroke, but if you do neuropsychological testing, behavioral disorders, and look at mathematics, specialists, they find a lot of them have abnormal findings. So neuropsychiatric testing is very important. Sickle cell anemia, before they go to school, as they go to school, to check if they have any silent infarcts. So it's really not silent, okay? So there are abnormal neuropsychological tests. TIA again, it's a transient episode of dysfunction caused by focal brain, spinal cord retinal ischemia without trauma or infection. Usually supposed to resolve within 24 hours, and they're supposed to have normal MRI and CT scan, but now with new MRI, they're finding so-called TIA people who have no lesions otherwise, having abnormal infarcts, etc. So remember, this changing field, so silent infarct and TIA are becoming more important in sickle cell anemia because they may indicate or suggest that there are damage going on without having a stroke. So again, after the stroke, pediatric practice before the age of TCD, between 1 to 9 years, or the higher incidence, about 7.5 to 10%, depends on genotype. Neurological symptoms we talked about already. Diagnosis always been by a CT scan, MRI. And I want to mention Moya disease is very important because again in children with vascular Moya disease for in children and adults with vascular occlusion, a lot of collateral vessels, and they can form like a small, we call puff of smoke, small vessel collection can bleed or have thrombosis sometimes. That's called Moya. It's been associated with sickle cell anemia because of vascular occlusion. I'll show you a percent of patients in a few minutes. So that's another complication of sickle cell anemia and vascular disease can get Moya. So diagnosed by clinical suspicion, do a neurological exam, a CT, and get ready for transfusion. So terminology we're using sickle cell syndromes. We talked about genotypes, phenotypes, talked about spectrum of stroke. Primary prevention, we talk about in a few minutes, how to prevent primary strokes, treat as acute stroke, and how to prevent secondary strokes, and stop 1 and stop 2 studies, hydroxyurea, and the newer studies. So as I said earlier, SS genotype is the most severe in clinical symptoms also for stroke. And S-beta-0 comes next. So SS and S-beta-0, the highest incidence of stroke. I've now seen in my experience over many years, S-beta plus a genotype. I've seen actually 2 cases, SC and stroke because there are other complications and severe dehydration, etc. Hereditary person, I've never seen a stroke in high F. So SS and S-beta-0 are usually the most common. That's the one we ask for screening, unless there's some other specific complication. So all children with SS, S-beta-0 are the higher risk, should be screened from 2 to 16 years of age. So genotype of SS and S-beta-0, phenotype, the increased severity of disease and clinical cause, as I said, and some children with S-beta plus or SC disease with very severe cause, multiple, you have to be careful. Viral infections and acute chest syndrome, higher risk. Lower steady hemoglobin, higher risk. High WBC because of increased viscosity and aggregation, risk of stroke is higher. Reticulocytosis, again possibly. High blood pressure, kidney disease, and so some studies show steroids given high dose for a long time that was pretty exposed to SCI and to stroke. If a history of asymptomatic TIA or seizures, this risk may be higher for getting obvious stroke also. Other modifying factors are many of them, especially in children and adolescents, smoking, birth control pills, if you are undiagnosed thrombophobia, other vasculopathies like maybe lupus, etc. And one thing in pediatrics I want all of you to remember is, actually we did a study in Tulane and LSU and children long ago. Children with snoring and sickle cell anemia, we studied them for obstructive sleep apnea, and they certainly have a higher incidence of stroke at night because they're sleeping, they're hypoxic. You and me, if you snore, your wife will beat you up and wake up. But in children with sickle cell anemia, they can cause stroke. So tonsillectomy, treatment of OSA, very important for patients with sickle cell anemia and sleep apnea. Keep these other things in mind. Okay. Again, we talked about this already. I will repeat that. Please remember, more than 20 years, risk of stroke is about 6%. So there's a peak between 1 and 9. Then again, after 25 years, there's another peak. And here's just to show you in the graphic fashion, for sickle cell anemia, SS disease, multiple strokes, and increased mortality. Just a couple of studies. I want to mention this study because if you're reading, look, this is it's an older study, but very good study. It's called the comprehensive sickle cell disease study, and they've followed patients for many, many years, and you have very good data from that study. Okay, and by 45 years, about 25% have got stroke, combined hemorrhagic and thrombotic stroke. And if you look at by 35 years, 50% had subclinical or cerebral infarct, silent cerebral infarct. Just shows you how extensive the CNS disease is. We don't know about it. Okay, really scary. So this affects their lifestyle. It's very, very important. It's very high incidence of, by the time they're 35 years of age, combination of infarct and stroke is very, very high. It is just to show you this incidence of stroke is going up very high. More of it is hemorrhagic stroke as they grow older, but combination is really high as they grow older. Okay, this is again an issue. I'm not going to stress on this issue, but adult hematologists often don't believe in continuing chronic transfusion for these people. That may be another reason why they get higher risk of stroke. This again, the follow-up is to remind you of the incidence. Ischemic stroke is common 2 to 9 years, uncommon from 2029. There's a second peak of 29. So please remember, as they grow older, risk of ischemic, the thrombotic ischemic stroke, bleeding stroke goes up. Okay, so pathophysiology, I can't go into detail just for you guys, but the multifactorial, not just because sickle cells or sickle cell causing endothelial damage, there's a constriction and thickening of the vessels, abnormal flow. Normally, God is very smart. When the blood flow, the platelets are in the middle. They don't come to the vessel wall at all. But when circulation slows down, there's damage, the viscosity changes, the blood flow changes, platelets come in contact with the endothelium, they stick to the endothelium and cause bleeding. So multiple factors: decreased oxygen saturation, vasculopathy, flow, viscosity, endothelial alterations, addition molecules. So that's addition. So multiple factors cause incidence of stroke, not just platelets or maybe thrombophilia. We don't know. So multifactorial, difficult to treat with aspirin or antiplatelet activities. Nobody's ever shown it works at all. So multifactorial, almost like diabetes, multiple factors causing vasculopathy. So acute stroke, all of you talked about already. Please remember the diagnosis by CT scan, MRI. No, don't consult. People consult what are called stroke people, critical care. Don't consult. Call hematology, blood bank. Get as quickly as possible a blood typing done. Do an exchange transfusion as quickly as possible to increase hemoglobin A, decrease hemoglobin S. So stroke will subside. There are better resolution. So as Dr. Gutierrez said earlier, the most important thing is quick movement, transfusion, exchange transfusion if possible. Older patients, you can erythrophoresis. So this here is again just to show is an overt stroke. And see almost white hemiplegia. A silent stroke, just infarct. I don't know if you can see my arrow here. This is silent, multiple. The healthy child, when MRI for some other reason, sickle cell anemia, fine infarct. And they do have neurocognitive impairment. So this is the TCD is what we're going to talk about. We've got about 20 minutes left. This is one of the most innovative things found in sickle cell anemia. I'm very glad because I was part of the original studies with Dr. Adam from Georgia. It was many, many years ago. I was a junior faculty at that time. But basically, it's a non-invasive ultrasound. They use different transducers to go through the skull. After 18 years, it's not very useful. Up to 16 to 18, especially 16 is very useful. We look at the multiple vessels around the brain, the brain and circular villus, look at abnormal flow. And we already talked about that. This is a study, originally 1994. So first we studied a lot of normal children looking at the flow. We did a lot of children with sickle cell anemia looking at the flow. Please remember, sickle cell anemia have different flow than from normal children. We have to study thousands of children, normalize what is normal, what is abnormal. Then the stop. One trial started in 1997. It's a study to prevent stroke by giving them transfusion in high-risk patients. This is the transcranial Doppler. Almost every hospital, I'm very lucky, very proud to tell you that in Louisiana, we have our centers in New Orleans, Baton Rouge does a very good job, Alexandria, Monroe. I think everywhere they've got these machines available now. Radiologists trained to do that. So it's very easy to get them all. Every child between 2 and 16 have this done, okay? So it's the protocol with SS and SB0, so all children 2 to 16 years of age. Above 16 years, no road for screening. It's an abnormal study. Again, I don't want to go into detail, but we have done flow velocities to know what is abnormal, what is normal. If it's more than 170, they repeat yearly. So the definite protocols available. About 200 is what we care about immediate stroke. Okay, what we do is we repeat it within 2 weeks. It's still abnormal because sometimes infection, blood pressure may change it. So do repeat it in 2 weeks. Still abnormal. Then we do an MRI, and a candidate for chronic transfusion. This is the abnormal values again. Those who are doing ultrasound, they know what it is. This again, just to show you correlation of TCD to stroke to a normal TCD. If you have abnormal TCD, boom, boom, you get multiples. Just because stroke is very, very high. So again, this is the original study that showed that if you had TCD and stroke, you have to correlate abnormal TCD with increases of strokes. Okay. And the next study, again, I'm very proud that LSU, Tulane, and Children's are part of the study. I'm an old guy, but I only 1 or 2 papers in New England Journal. This is one of our papers. I was the 20th author, but I'm very proud that as part of the study because really changed the scenario of sickle cell. So you just realize how important a study as a group study becomes. We had almost, I think, about 28 hospitals across the country that are doing this, and Children's and Tulane and LSU are part of that. So it's published in New England Journal of Medicine. This is a remarkable study because we had to stop the study in 20 months because we found out those who were not transfused. There's a random, very, very well controlled. Those who were not transfused were getting so many strokes that is not correct continuity anymore. So only one person got stroke and transfusion arm, whereas 10 in the other arm. So the study was stopped after about 20 months, and the paper was published and became standard treatment for doing TCD and transfusion. This is a study again. I'm not going to detail, but it showed that if you had transfusion, you had no strokes, you had no transfusion, you had high incidence strokes. Again, this is a graphics to show the stroke, big difference in transfusion with no transfusion. So the next study was top 2. We started transfuse, but how long to transfuse? This is a big issue in CNS and stroke. And I'll tell you a few stories later on, but the second study was done to find out about 80 children. Those who received transfusion for 30 months and normalized TCD, we stopped the transfusion. Among those who stopped the transfusion, we stopped some of them and continued some of them. Those who stopped transfusion for various reasons, there were two more strokes and 14 had abnormal TCD again. But those who continued transfusion, there were no strokes but normal TCD. So we really have no conclusion on how long to continue transfusion. But if you have abnormal TCD, transfuse them, they don't get stroke. If abnormal TCD, transfuse them, stop after 2 years, there's still risk of stroke happening again. So just keep that in mind, okay? So evidence of success, another evidence of success again, California has got large number of, they follow patients for, let me see one, yeah, for this details from California studies, the follow-up of patient after hospitalization. You can see here that the risk of stroke was 0.88 per 100 years. 1999, they started transfusing patients after 0.56 per 100 years. Definitely decrease in sickle cell anemia after transfusion of patients, prophylactic transfusion. So this is a stop study. Again, this is an old picture of mine. I show the picture because this is 2 of my patients sickle cell anemia. When you become 18 years, if this is olden days, 18 years, we will transfer adult care. This doctor went to one of my adult hematologists in town who continued transfusing. He's in his 30s now, no more stroke. This guy went to a different doctor, doesn't believe in transfusion. Or, I mean, there's no proof, so I don't, but he had multiple strokes, a double hemiplegia. One day he walked out of his house and then never came back. Nobody knows what happened to him. So please remember, strokes do treat transfusion, prevent recurrent transfusion. I have had a patient in Detroit that we transfused for almost 15, 16 years. Then we stopped the transfusion, within 9 months got stroke again. So I don't know what the pathology is, but really, only thing that keeps him not getting transfusion, stroke is chronic transfusion. So the high mortality, you can also get a lot of complications. Okay? This is a study a paper that we published about the patient I talked to earlier, who had a stroke. He had not, in addition to stroke, CVA from sickle cell, he also had Moya disease. It's called Moya disease. Okay, this is Moya disease, called a puff of smoke. So this patient had stroke, required transfusion, but because of Moya, the risk is very high of getting stroke again because they can bleed. So you had a neurosurgical involved. So neurosurgery gets involved. There was a lot of techniques to increase the blood flow out of the Moya. So child had neurosurgical intervention. And this here a picture of him now. He's almost 15 years of age, going to school, doing very. He loves medical school. He shows all his reflexes to them. He loves medical students. He's 15 years old and doing well. Okay, but had sickle cell anemia, stroke, and moya. So both were corrected. Chronic transfusion, chelation. He's doing very well after almost 12 years. Again, I just want to show you my students, neurosurgery, hematology, everybody working together. So treatment is exchange transfusion, and I'm not going to go into detail of chronic transfusion. The principle is to, if you give them blood, the bone marrow shuts down, doesn't make any more sickle cell RBCs, there's a high amount of hemoglobin A, decrease S. So principle is to keep S below 30%, A above 70%. The older patient got erythrophoresis, we remove the sickle blood, give them fresh blood, complete replacement. Advantages, less blood volume, less risk of iron overload. Otherwise, with exchange transfusion, partial exchange, erythrophoresis. Definitely, phlebotomy helps a lot. So erythrophoresis is the best if you can, older people. And if you're alloimmunization, we've got multiple blood products. African Americans get blood from Caucasian and antibodies. Make sure they're well matched to an alloimmunization. Iron overload, again, today we've got very good chelating agents. All the patients are well chelated, they're compliant, oral chelation. So between acute exchange transfusion, chronic transfusion, chelation, and good blood product selection, they're doing much better than in the past. Okay, so chronic transfusion, we talk again, because when to stop chronic transfusion? As it stands now, I mean, I don't know whether Shashi or anybody has any comments, but very difficult to stop them. I personally feel that should continue, at least longer they're in my control, continue them with chelation, they're going to get strokes. We had a couple of patients who, where one patient just, for some reason, missed transfusion for about a month, and S went to about 40% and a stroke. So we're very careful about maintaining good hemoglobin A. Best is about 70%, but at least 50-60%. But in general, 70-30 is a ratio that we like to have. Of course, you can track hydroxyurea. There have been no clear studies. There have been studies when it's called a switch trial, where we give transfusion, then stopped, and for those who could not continue transfusion, give hydroxyurea. They had some benefit, but hydroxyurea alone, there's no good study to show they can prevent stroke. I'll come to that in a few minutes, but so chronic transfusion is a treatment. Hydroxyurea being tried. Bone marrow transplant, definitely for those with sickle cell anemia and severe crisis, it is prophylactically done. It can prevent stroke. But once you had a stroke and for the BMT, the symptoms don't get better, but probably the risk of stroke again is slightly lower. So hydroxyurea, no trial. The recent study from Nigeria, they were using 10-20 milligram per kg, showed benefit to increase hemoglobin F, decrease retic, and increase hemoglobin F, and stroke was slightly decreased at all. So this is a very newer study. I don't know how well, I've not read it carefully, but basically showed that hydroxyurea prophylactically given this dose had decreases of stroke in their population of patients prospectively. Okay, but it needs at least 6 months to get good levels of hemoglobin F. A following French study showed no effect of hydroxyurea at all, unless they were post-transfusion. Okay, so compliance is difficult, toxicity is very minimal, response very variable, but hydroxyurea in pediatrics is very well tolerated. So at this point in time, and the hematologist knows that every patient with sickle cell anemia, by 9 months, if one of my colleagues started 6 months, hydroxyurea started to decrease pain crisis, complications, and hopefully long-term damage to organs. We feel that they're not sickling, their kidneys, heart, lungs will function better later on. Okay, so BMT, as I told you about, is an option available. In fact, I personally feel at this point in time, only curative therapy for sickle cell anemia is BMT, just like thalassemia. If you have a donor available, the course is severe, depending on how to judge severity. If it's done before 7 to 10 years of age, probably the prognosis is much better than doing it later on in life. So that's an option. The newer medication, glutamine, voxelotor, etc., have not shown, no study showing that decreases stroke at all. So stem cell transplants, I told you, offer complete cure. So I just want to show again about Louisiana. The first transplant for sickle cell done by Dr. Yu at Children's Hospital LSU in about early 1990s, if I remember right. Again, this child particularly had some history of seizure, but did very well after transplant, doing very well. Again, just for the Louisiana audience people, first transplant in Louisiana was not done in Tulane or Oxnard or any big hospital, but in Charity Hospital. This is Dr. Donald Thomas from Seattle. Shashi might know him, but he was the first one to transplant in the US many years ago. He came to help to inaugurate our transplant program. These are our transplant doctors, sickle cell doctors, Dr. Odie. So a group that was transplant many years ago. So again, this is the first transplant with Dr. Yu. Right now, it's an option available. There are studies going on about sickle cell transplant, doing with different ways of, but again, because of the cost, risk of transplant still not as popular as gene therapy. I won't go in detail, but at this point in time, we don't have details to say that it prevents stroke. So in general, we have about 15 minutes left. So sickle cell requires a really good team. The most important is the patients and the parents. And I'm very proud to say that at least in our population in New Orleans, with Pediatric, Tulane, LSU, Children's, Oxford, etc., our parents are very well informed. They're taught a lot of things by nurses and nursing educators. And the children are also taught about sickle cell anemia. So our pharmacists are very good at making hydroxyurea for small children. Social workers, psychology, psychiatry. Blood bank was a very crucial role, especially for X-ray and transfusion, chronic transfusions. We had patients who go to small hospitals, small blood banks, and they give the blood bank is very careful because you give them random blood donors, you get antibodies that can prevent transfusion later on. In neurology, neurosurgery, ophthalmology, dental, and of course, most important, the pediatric practitioner. So I told the Sickle Cell Foundations in Louisiana play a very important role in education, getting patients to come to a clinic, etc. And different clinics in different parts of the state. We have got multiple sickle cell clinics run by Baton Rouge Children's, Oxnard, Lafayette, etc. Dr. House and Dr. Gerodi, etc. And across the state, Dr. Gardner and Children's. So we're very proud to have a good system. And this is the same patient I told you earlier, the little guy here. He loves our patient on our clinic. We love him too. He's doing very well in school. Post-stroke, a little bit of a hemiparesis, and slight fish, but speaks. He had aphasia, could not speak, but come back to almost normal. Again, as I said, I got a lot of references you can read, but if you can just read that, the NHLB article that covers almost everything to do with sickle cell. There was some newest, Dr. DeBon does a lot of work in sickle cell and stroke. It's probably a third in the world on this, got multiple papers all the time on silent infarct, strokes, TI, etc., and what to do. Again, if you're nice to your patient, they hug you and give you a kiss. If not, they'll give you a bite. Okay, so. And I just want to mention one more thing. The Louisiana Sickle Cell Commission is now working with the family health program in Louisiana State. They have a sickle cell disease care pathway, educate pediatricians, healthcare people. Foundation. This is one of the earliest things that we're trying to do to make a pathway for everybody. I'll stop there and take some questions. Got about 10 minutes left. Okay, so that's what Julie wanted me to do. So in summary, sickle cell anemia is a very, very, very prevalent disease in Louisiana and across the country. And we have improved the mortality and mortality in children significantly by, again, immunizations, good care, newborn screening, antibody prophylaxis. But as they grow older, they're getting still chronic damage to the organs because sickling is going on in the kidney, heart, pulmonary. So we're going to try to prevent that by doing hydroxyurea prophylaxis, good better care. But strokes, because of TCD, early monitoring has come down dramatically. So what I want to do for the audience, for the public, is every child between 2 and 6 should have ultrasound done. And the foundation commission make sure that it's done, they followed up as required. So prevention of stroke is very important, sickle cell, because high mortality, morbidity, lifetime. And adult care across the country has improved, but still has to improve even more, especially in relation to chronic complications. So I'll stop there, take some questions or comments from anybody.
Dr. Gordon had a question. Dr. Gordon, we can't hear you. You might want to unmute from your phone.
Stuart, you have a question, Stuart? You are my chief resident many years ago. I should have told everything he knows, okay? Stuart, are you there?
Yes.
Can you hear me now?
Yes,
I can hear you.
got it.
I don't know what happened. The double mute. Hey, Raj, okay. Thank you. Very nice presentation. Quick question.
Yeah.
I think the kid, I work for one of the Medicaid plans now, and the kids are pretty well cared for, as you've demonstrated. The adults, on the other hand, what do you suggest, or is there something in place we could put in place to help adult sickle cell patients get better access to hematologists, or are there a certain group of primary care docs that like to take care of sickle cell?
Yeah, Stuart, that's a very good question, Stuart. Very good question. Good to hear you, Stuart. Very good question. Superb question. In many parts of the country where there's a good, they've got transition clinics, and from where you can transfer from pediatrics to adult. And we had tried that. So when you had I mean, 30 years ago, when you had a clinic at Charity Hospital where adult and pediatric, you all were together. The adult, and they're 15, 16, adult guy will come and see them. They would transfer the patients over. But it has become, for a few years, difficult. But now again, the last 5, 6 years, there are more and more like cancer AYA clinics trying to transition properly. In Oxnard, we have a clinic now from pediatric to adult that transition. Tulane has a clinic like that. But in general, I would agree with you across the state. A few years ago, we did a survey. There are only about 4 hospitals that are willing to take care of adult sickle cell patients on a regular basis with follow-up. So it's becoming more now, but there's a big need for med-peds doctors, adult hematologists we know all in pediatric case. So sickle cell camp, sorry. So it's a big issue. There are many hospitals in the world now, in the country now, got transitional care clinics where they're, but everywhere is a difficult problem because of insurance, compliance, and they seem to be having drug problems, etc. It's very difficult to get a lot of adult hematologists be involved in sickle cell care. But it's changing gradually as we're training more people from pediatrics to med-peds people also. That's a good question, sir. No good answer to that.
Thank you.
Anybody? Any other questions?
Feel free to unmute to ask your questions. You don't need to raise your hand or anything.
I want to just stress again the fact that I'm proud to be from Louisiana because we really have one of the best across the state Sickle Cell Foundation Commission working together. We meet quite frequently, discuss the issues, but unfortunately, the problem is, again, not being mean, but funding across this, for a lot of research, etc., much less. It's more than earlier, but much less than many other programs. So, but in Louisiana, we have good basic public health foundation, state commission, a lot of clinics across between Shreveport, LSU, Tulane, and Baton Rouge. A lot of doctors working towards sickle cell. Any other questions?
What was that entity? That entity you referenced a few minutes, is like the second to last slide. There was an entity that had a guideline or a recommendation.
Yeah, it's one second. I'll show it to you. 1 second. I can't share anymore.
I'll let you share. Hold on.
Okay.
There you go.
1 second. Sorry.
Yeah, that one.
1 second. I'm sorry. I'm sorry. Don't get a headache. Don't get seizures. I don't know how to go back so fast. Okay, 1 second.
Was it NHLBI?
Exactly. That's the one. Yeah. Can't write it. I'm sorry. Yeah, this is the best. The JAMA 2014 or NHLB publication. If you just read this, you don't need any more sickle cell doctors at all. It's I think all pediatricians, all public health people, all people with sickle cell, taking care of sickle should read this, okay? It tells exactly what to do, the recommendations. The new recommendation, American for hematology, for hematology, that's not more important. This is more important for everybody. So. Okay, any other questions? Shashi, are you still there? Okay, good. He's a hematologist from Utah who took part. So, okay, guys, any other questions, anybody?
Okay. If there's no more questions,
no.
If there's no other questions, we'll finish up with a little bit of housekeeping. We have Louisiana AAP has a couple of upcoming events. So let's get back to the kids. Coming up next week, the chapter will be having first, take your evaluation. Don't forget you want your credit. Your evaluation is required for credit, and even if you don't need credit, it's great for us to have the data.